Hello everyone, my name is Sharon Joseph and today I'm going to do a PowerPoint presentation of mental health needs of special population in primary care settings. Mental health in primary health care involves screening, diagnosing, and treatment of a variety of mental health disorder. Mental conditions can be managed in primary care if there is no risk for suicide, no history of substance abuse, and if there are no psychotic symptoms. Benefits of integrating mental health services into primary health care. The number one benefit is it reduces the stigma for people with mental health disorders and their families. Primary health care is not associated with any specific health condition. Therefore, patient and family members will be far more comfortable in seeking medical care for their medical condition than a specialty services, psychiatry services. Then the second benefit is it increases access to care. Primary health care is easily accessible to any individual compared to other specialty services. And the third benefit is improved detection and prevention of mental disorders. Since primary healthcare workers are frontline and often first level of contact, equipping primary care provider to screen for a variety of mental health conditions enables early detection and implementation of appropriate treatment. Let's look at the mental health in elderly in primary care setting. 20% of people age 53 or old, 55 years or older experience some type of mental health concern. The most common mental health condition in the elderly population include anxiety, severe cognitive impairment, and mood disorders such as depression. 2015 National Survey on Drug Use and Health found that about 43.4 million adults in the United States have mental illness in the past year, 14% of which are age 50 and above. In 2013, the non-institutionalized spending on mental health illness amounted to about $89 billion. So the screening of mental health condition in elderly patient. United States Preventive Services Task Force recommendations for mental health screening in elderly patients are depression screening, unhealthy alcohol use screening, and behavioral counseling intervention, cognitive impairment screening. According to USPSTF, evidence is insufficient to assess balance and benefits and harms of screening for cognitive impairment in older patients. In case if screening is considered, mini mental status evaluation is a useful instrument in detecting dementia. Depression screening. Risk factors in older adults for depression include disability and poor health status, related to medical illness, complicated grief, chronic sleep disturbance, loneliness, and history of a depression. Commonly used depression screening instruments are Patient Health Questionnaire 9 and Geriatric Depression Scale. Patient Health Questionnaire, there are about 9 questionnaires regarding their mood that the patient has to check, and the healthcare provider adds up the numbers and comes up with the Patient Health Questionnaire score. The interpretation of the score results are as follows. If the score is between 1 to 4, the patient is diagnosed with minimal depression. If the score is between 5 to 9, diagnosed with mild depression. With a score of 10 to 14, the patients are diagnosed with moderate depression, and a score of 15 to 19, moderately severe depression. 20 to 27, the patients are diagnosed with severe depression. The geriatric depression scale, there are two types, short form and the long form. Short form has 15 questionnaires and long form has 30 questionnaires. The score interpretation are as follows. A score of 0 to 9, normal, no diagnosis of depression. Mild depression if you have a score of 10 to 19, and severe depression if you have a score of 20 to 30. Alcohol screening in elderly population. USPSTF determined that 1 item to 3 item screening instruments have best accuracy for assessing unhealthy alcohol use in adults. The instruments widely used are the Alcohol Use Disorder Identification Test, consumption, and the NIAAA recommended single alcohol screening question. Brief behavioral counseling intervention in adults who screen positive are associated with reduced unhealthy alcohol use. Treatment of depression in the elderly population. Effective management includes psychotherapy as well as pharmacotherapy. The psychotherapy such as cognitive behavioral therapy, etc. They are found to improve quality of life and medical health status. It also enhances the functional capacity. The improvement in depression is seen as early as 2 weeks from the start of therapy. For the full therapeutic benefits to take place, it takes usually about 6 to 12 months. Pharmacotherapy for treatment of depression in elderly patients. The first line medication is selective serotonin reuptake inhibitor. It's a drug of choice for treatment of most type of depression with or without psychotic features. SSRI have been found to have low incidence of sedative and anticholinergic effects. They have little or no influence on cognition and fewer adverse cardiovascular effects. The common side effects are fatigue, weight loss, agitation and insomnia, dry mouth, nausea and diarrhea, headache and anxiety. When do we consider referral to psychiatry for an elderly patient? These are the following conditions. If the patient has a diagnosis of bipolar disorder, the patient has suicidal ideation, the patient has psychosis at the time of presentation, if they're unresponsive or intolerant to adequate trial of first line of treatment, and if they have any uncertain or complex diagnosis, or if they are severely ill. If you notice any of these above conditions, a referral to the psychiatry should be made. Of alcohol use disorder for mental health in elderly population in primary care setting involves the use of mnemonic SBIRT, where S stands for screening, BI is brief behavioral intervention, and RT is referral to treatment. Brief behavioral counseling intervention in adults who screen positive are associated with reduced unhealthy alcohol use. Some of the intervention used for brief intervention are use of personalized normative feedback session, in which the participants were shown how their alcohol use compares with that of others. Personalized normative feedback was often combined with motivational interviewing or more extensive cognitive behavioral counseling. Initial treatment of alcohol disorder include abstinence from alcohol use, reduction or moderation of alcohol use, and the clinician and the patient sign an agreement and it is documented in the medical record. The mental health condition of perinatal lactation in primary care settings. Perinatal depression is the occurrence of depressive disorder during pregnancy or following childbirth. Perinatal depression can affect as many as 1 in 7 women, and it is one of the common complications of pregnancy and postpartum period. And the disease burden is the perinatal depression poses a negative short and long-term effects on both mother and child. The screening for perinatal depression. USPSTF recommends screening for depression, and commonly used screening instrument is Edinburgh Postnatal Depression Scale in postpartum and pregnant women. The 10-question Edinburgh Postnatal Depression Scale is valuable, and it is an efficient way of identifying patients who are at risk for perinatal depression. Mothers who score above 13 are likely to be suffering from depressive illness of varying. And the treatment, the USPSTF recommends that clinicians provide or refer pregnant and postpartum persons who are at increased risk for perinatal depression to counseling intervention, such as cognitive behavioral therapy and interpersonal therapy. They are very effective in preventing perinatal depression. And if they have been diagnosed with a score of more than 13 and have the diagnosis of depression and pharmacotherapy and other therapies indicated, then a referral to the psychiatrist should be made. Pregnant and lactational mothers can also be screened for alcohol use screening, and mothers should be encouraged to stay away from alcohol during the pregnancy time because of its negative effects on the child. Moving to the medical needs of the pediatric or adolescent age group. Children and adolescents with depression has functional impairments in their performance at school or work, and it also affects their development. Depression is also associated with recurrent depression later in adulthood and other mental disorders, and the increased risk for suicidal ideation or even an attempt. The screening, USPSTF recommends screening for major depressive disorder in adolescents aged 12 to 18. There is no evidence about benefits of depression in screening in children less than 11 years of age. Two instruments that have been most often used are the Patient Health Questionnaire for adolescents and the primary care version of Beck Depression Inventory. Again, the same thing, the Patient Health Questionnaire for adolescents includes 9 questionnaires regarding their moods the patient has to check, and the healthcare provider adds up the numbers and comes up with a PHQ score. And the interpretation of score results is 0 to 4, there is no depression. Score between 5 to 9, mild depression. Score between 10 to 14, moderate depression. Score of 15 to 19, moderately severe, and 20 to 27, severe depression. The Beck Depression Inventory consists of 21 questionnaire, which describes that how the patient has been feeling for the past 2 weeks, and then they are scored. Treatment for major depressive disorder in pediatric or adolescent age group include pharmacotherapy, psychotherapy, collaborative care with the psychologist, psychosocial support intervention, complementary and alternative medicine approaches. I'm going to briefly be talking about the pharmacotherapy. The medication approved is fluoxetine, is approved by the FDA for treatment of depressive disorder in children aged 8 years or older, and escitalopram is approved for treatment of major depressive disorder in adolescents aged 12 to 17, and pediatric population should be monitored appropriately after the start of the medication, and they should be observed closely for any clinical worsening, suicidality, or any unusual changes in the behavior. Moving to the mental health needs in the LGBTQ population, lesbian, gay, bisexual, transgender questioning, and other sexually minority and gender diverse population, they face very unique challenges. They are at increased risk of experiencing shame, fear, discrimination, and the adverse event that can lead to mental health condition. These negative experiences and trauma place them at a greater risk for severe mental health condition, including depression, anxiety, post-traumatic stress disorder, and suicidality. The screening for the LGBTQ community is the same as the adult population. The depression screening with the PHQ-9 questionnaire, and the alcohol use disorder screen with AUDIT-C. The treatment, effective management include combining psychotherapy and pharmacotherapy. Psychotherapy includes referral to psychological services for various therapy that they offer. They are found to improve their quality of life and medical health status, and also improve their functional capacity. The pharmacotherapy includes the first line of medication that's used is selective serotonin reuptake inhibitor. And the immigrant mental health condition of the immigrant or migrant workers. Experience of migration and resettlement in a new country is associated with mental health risk. Some of the prevalent disorder among immigrant or migrant migrant workers are depressive disorder, anxiety disorder, substance use disorder, and psychotic disorder. Screening is same as the other. For the depression, we use the PHQ-9 screen, and substance use screen would be audit C. Again, similar psychotherapy and pharmacotherapy. Psychotherapy is cognitive behavioral therapy and other form of therapies. They're found to improve their quality of life. And pharmacotherapy includes selective serotonin reuptake. And for the alcohol use disorder, we use a mnemonic SBIRT, which includes screening, behavioral intervention, and referral to treatment. Thank you for listening to my presentation. Have a good day.